Dear friends and colleagues, we now go on to the second lecture. I'd like to thank again the organization. It is a pleasure to be speaking for this conference. Now we're going on with malignant sweat gland tumors, an update. So this is a rather complex topic. We'll talk a little bit based on clinical cases that we will discuss. So we'll talk a little bit about general features and classification, histogenesis, biological behavior, the distinction from cutaneous metastasis, some cytogenetic abnormalities, and then we will conclude with some closing remarks. So malignant sweat gland tumors, they represent a significant challenge in dermatology and in dermatopathology in particular, because they are very rare. There are many entities with a confusing nomenclature, and many of them have overlapping histopathological features. Some of them may pose problems of differential diagnosis with metastatic tumors, and the prognosis may be difficult to predict because many cases have few case reports or small series, and so there are usually no standardized treatment options, especially for advanced cases. In most cases, surgical excision is the gold standard. So this is the current classification of malignant sweat gland tumors. As we can see here, there are a lot of entities. Will not go through all of these. So I opted for showing some examples and then discussing some specific problems in the diagnosis of sweat gland tumors. So I start with a case from our department, a male patient aged 78 years old who presented with an erythematous to violaceous nodule on the left cheek that was stable for many years, and then it suffered a rapid growth in the previous year. It was partially cystic on biopsy, and the initial biopsy was not conclusive and just showed a basaloid neoplasm. You can see here more detail, the violaceous lesion. It was rather soft on palpation. And this is the histology of the excision specimen. We can see here that there is a well circumscribed nodular lesion with solid and cystic areas. Here we can see that the neoplasm looks rather basaloid. That was shown in the partial biopsy. It is composed of relatively small cells. And here, in more detail, we can see there is somewhat trabecular growth with some smaller cells at the periphery of this trabeculae, and some larger cells at their center. And there are also scattered lymphocytes. So this is the picture that we usually see in a spiroadenoma. However, there were areas in which we saw loss of that dual cell population. There was cytological atypia, not very marked, but there was cytological atypia, loss of the biphasic cytological pattern, and mitotic activity. And we also see a loss of the scattered lymphocytes that were present in the spiroadenoma areas. So we diagnosed it as a morphologically low-grade spiroadenocarcinoma. So the lesion was still well circumscribed, and there were areas still recognizable as a spiroadenoma, but there were areas of malignant transformation. So it was a morphologically low-grade lesion. Follow-up did not show any evidence of disease at 5 years, so confirming this low-grade aggressiveness of the tumor. So this is an example of malignant neoplasms that arise from spiroadenoma cylindroma or spiroadenocylindroma. So they are part of a morphological spectrum. They may be sporadic or associated with Brooks-Pigler syndrome with sealed mutations, and they may be morphologically low grade or high grade. So in this morphology correlates with the biological potential, which is important. So the typical clinical features is the rapid growth of a long-standing lesion, sometimes with ulceration. They present more commonly on the head and neck, and in Brooks-Spiegler syndrome, they're especially common on the scalp. So the histological features are quite variable. In low-grade tumors is usually the loss of dual cell population, the infiltrative growth, mild to moderate atypia, mitosis, loss of basement membrane, and loss of the lymphocytes. A little bit some of these features we saw in our case. Higher grade tumors, they can present also with very variable morphology, like basal cell adenocarcinoma, like adenocarcinoma not otherwise specified, or even cases of sarcomatoid carcinoma. We should see at least focally a benign component to diagnose confidently these neoplasms. So these neoplasms that arise from spirodenomas and cylindromas are part of the lesions that have a benign counterpart. So there are in malignant sweat gland tumors a group of lesions that has a benign counterpart like porocarcinoma and adenocarcinoma, and here on the right we see quite a number of neoplasms that don't have a known benign counterpart. We go on with another case report. A male patient aged 72 years old, lesion on the left cheek. Clinically, the clinician thought of basal cell carcinoma. We don't have a clinical picture for this one. We can see that there is a nodular, somewhat basaloid on low power, somewhat basaloid neoplasm with some cystic areas that appear to have a bit of mucinous material. Here on higher power, we see that the cells don't look like the cells of basal cell carcinoma. So they have more cytoplasm, they are larger, they don't have good going peripheral palisading, so this doesn't look like a basal cell carcinoma. And we see also areas that have lots of mucin forming these large pools in which we see epithelial islands floating in. Immunohistochemistry showed positivities for cytokeratin 7, for neuroendocrine markers like chromogranin and synaptophysin. EMA highlighted ductal structures, and the lesion was also positive for estrogen and progesterone receptors. So this is a typical example of an endocrine mucin-producing sweat gland carcinoma that had also areas of mucinous carcinoma, these areas with more mucin. Endocrine mucin-producing sweat gland carcinoma is a rare, low-grade neuroendocrine neoplasm of the skin, which is the cutaneous counterpart of solid papillary adenocarcinoma of breast. It typically presents in elderly patients with the predilection for females. There is a predilection for the eyelid and periorbital skin, and there is a presumed origin from eccrine ducts because sometimes there is an in situ component. Histologically, they are usually well circumscribed. They can be solid, cystic, papillary, or cribiform, so there may be a combination of patterns. They have intracellular and extracellular mucin. They typically have low mitotic activity and low proliferation rate with Ki67. And they are positive for neuroendocrine markers and for progesterone and estrogen receptors and for gross cystic disease fluid protein 15. So it may be a precursor of mucinous carcinoma, and in some cases, like our case, we can see a mixture of the two lesions, so an endocrine mucin-producing sweat gland carcinoma with areas of mucinous carcinoma. They tend to have a good prognosis with risk for local recurrence, but usually no metastatic potential. So this highlights the fact that, and this list that I have here in these two lists in the slide, highlights the fact that malignant sweat gland tumors are heterogeneous in terms of biological behavior. So there are lesions here on the left that have low-grade malignant potential, And this is the case of endocrine mucin producing sweat gland carcinoma and also mucinous carcinoma. On the other hand, the list on the right has examples of neoplasms that have high-grade malignant potential. And I'll just show a few examples of other neoplasms with low malignant potential, and then some that have high-grade malignant potential. So with low-grade malignant potential, one of the most known ones is microcystic adnexal carcinoma, which is characterized by these keratin-filled cysts on the surface of the lesion and then a deeply infiltrative um, behavior towards its deepest portion, and usually with ductal differentiation. So this is a neoplasm that is rather bland cytologically, so it has an infiltrative growth. It tends to recur, but it doesn't metastasize. And the same here with primary cutaneous adenoid cystic carcinoma, which is characterized by this infiltrative, typically cribriform pattern. We can see here perineural invasion. So when it is primary cutaneous, it tends to recur locally, but doesn't tend to metastasize. This is an example of another low-grade malignant potential neoplasm, which is mucinous carcinoma. I had already shown in our example some areas of mucinous carcinoma. And now a few examples of neoplasms with high-grade malignant potential. Porocarcinoma, which is the malignant counterpart of poroma. Hydradenocarcinoma, which is the malignant counterpart of hydroadenoma, and in fact this lesion had a benign component of hydroadenoma on the left and then a malignant component with cytological atypia and a more infiltrative growth pattern. And also digital papillary adenocarcinoma that tends to present on the digits, usually in middle-aged adult males. They can have in-transit metastasis and also lymph node metastasis and lung metastasis. This is another clinical case. A male aged 67 years old with a tumor on the right occipital scalp with a progressive growth for 3 years. We can see a deeply infiltrative neoplasm with some nests and cords. Even from this low power, we can see some clear spaces that suggest that the lesion has ductal or glandular differentiation. Here we can see a sclerotic stroma with these infiltrative cords. And here we can see an area with perineural invasion. Cytologically, this was a high-grade malignant lesion with pleomorphism, some apoptotic cells, and mitotic figures. Immunohistochemistry was positive for cytokeratin 7, estrogen receptors, and progesterone receptors, and was negative for cytokeratin 20. So the main differential diagnosis was between a primary cutaneous neoplasm and a cutaneous metastasis. The patient was staged and there was no evidence of an extracutaneous neoplasm, namely from the breast. So the differential diagnosis was the so-called the final diagnosis was the so-called adnexal adenocarcinoma, not otherwise specified. This carcinoma is also known as sweat gland carcinoma or eccrine carcinoma or eccrine ductal carcinoma. In fact, I used to prefer these terms, but the more recent nomenclature is adnexal adenocarcinoma, not otherwise specified. So it is a primary neoplasm with ductal and or glandular differentiation that lacks specific features of lesions conforming to other categories. It presents more commonly on the head and neck and more rarely on the trunk, but eventually it can occur at any site. EMA and CEA highlight the ductal structures. P63 and P40 should be at least focally positive, and other markers like cytokeratin 7, cytokeratin 5 and 6, and D240, calretinine may be also positive. The most important differential diagnosis, like I highlighted in our case, is with metastasis, especially from breast carcinoma. So the definitive diagnosis requires a close clinical pathological correlation, assessment of the immunohistochemistry, and of the histological features. So there are quite a number of adnexal neoplasms that mimic metastasis from different organs. The features that allow distinction between metastasis and primary cutaneous tumors are the location on the head and neck. This favors primary cutaneous origin. Also the presence of an in situ component, usually within dilated native glands, and some immunohistochemical markers like P63, calponin, SMA, and podoplanin. So these features favor a primary cutaneous origin. However, in most instances, full clinical investigation and staging remains the gold standard to exclude metastasis. Now, a few words just for cytogenetic and molecular abnormalities in malignant sweat gland tumors. They have been described in many of these neoplasms, but they rarely have practical implications in terms of diagnosis and management. So some of the most important examples are the translocations that can be found in secretory carcinoma, in hydradenocarcinoma, and in adenoid cystic carcinoma. I'd like to finish with a very interesting entity and rather distinctive, although very rare, which is secretory carcinoma of the skin. It is a rare primary cutaneous neoplasm which is analogous to the breast and salivary gland counterparts. It presents most commonly on the axilla, followed by the face, including lips, and they are more rarely seen on the trunk and limbs. They have a wide age range and seem to affect equally male and female patients. It presents as a nondescript solitary nodule, and it has a very distinctive histology. It is usually a well-circumscribed nodule with tubular and microcystic areas that have vacuoles filled with eosinophilic secretions. Immunohistochemistry is also distinctive with S100 positive, mammaglobin, STAT5A positive, GATA3, and NTRK more or less positive. They also have usually cytogenetic abnormalities. These are pictures taken from an article in which we see the usually well circumscribed nodule involving the dermis and sometimes the subcutaneous tissue. There are some cases which are a bit more infiltrative. And the distinctive features is the presence of these many holes in the neoplasm that are filled with these eosinophilic secretions. So in conclusion, I would like to say that sweat gland carcinomas are rare neoplasms, usually with non-specific clinical presentation. So the diagnosis relies mostly on histology, and the diagnosis is mainly made based on morphology. So this is the most important, but immunohistochemistry may help, and cytogenetic abnormalities in a few cases may also be helpful. One of the most important points is the distinction of some of these carcinomas from metastasis, and this distinction may be very difficult or even impossible only based on histology. So clinical pathological correlation and full workup of the patient are mandatory. Thank you very much for your attention.